For DIP flexion, the normal range is 0 to 80 degrees. The patient is seated with the forearm in mid position, the wrist at 0 degrees neutral deviation, and the forearm and hand supported on the ulnar border on a firm surface. The axis is on the dorsal surface of the distal interphalangeal joint. The stationary arm is placed over the middle phalanx, and the movable arm over the distal phalanx. For PIP flexion, the normal range is 0 to 110 degrees. The patient is seated with the forearm in mid position, the wrist at 0 degrees neutral position, and the forearm and hand supported on a firm surface on the ulnar border. The axis is placed centered on the dorsal surface of the PIP joint being measured. The stationary arm is placed over the proximal phalanx, and the movable arm is placed over the middle phalanx. For MP abduction, the normal range is 0 to 25 degrees. The patient is seated with the forearm pronated, the wrist at 0 degrees in neutral deviation, the fingers straight, and the hand resting on a firm surface. The axis is centered over the MP joint being measured. The stationary arm over the corresponding metacarpal. The movable arm over the proximal phalanx. For MP hyperextension, the normal range is 0 to 45 degrees. The patient is seated with the forearm in mid position, the wrist at 0 degrees neutral position, and the IP joints relaxed or in flexion. The forearm and hand supported on a firm surface on the ulnar border. The axis is placed on the lateral aspect of the MP joint of the index finger. The stationary arm is parallel to the metacarpal. The movable arm is parallel to the proximal phalanx. MP flexion has a normal range of 0 to 90 degrees. The patient is seated with elbow flexed, forearm in mid position, wrist at 0 degrees neutral deviation, and the forearm and hand supported on a firm surface on the ulnar border. The axis is placed on the dorsal aspect of the MP joint. The stationary arm on top of the metacarpal. The movable arm on top of the proximal phalanx.
MC flexion IP extension. Against gravity, the patient is seated with forearm in supination, wrist at neutral resting on supporting surface. MP joints are extended. Stabilize over the metacarpals proximal to the MP joint and the palm of the hand to prevent wrist motion. Palpate the first dorsal interosseous muscle just medial to the distal aspect of the second metacarpal on the dorsum of the hand. Observe the client flexing the MP joints and extending the IP joint simultaneously. Resistance. Provide resistance to each finger separately by grasping the distal phalanx and pushing it downwards on the finger into the supporting surface towards MP extension and IP flexion. MC flexion with IP extension. For gravity eliminated, the patient is seated with forearm and wrist in mid position and resting on the ulnar border of the supporting surface. MP joints are extended and IP joints are flexed. Stabilize at the wrist and palm of hand. Palpate as described previously the first dorsal interosseous muscle just medial to the distal aspects of the second metacarpal on the dorsum of the hand. Observe the client flexing the MP joint and extending the IP joint simultaneously. MC extension. For against gravity, the patient is seated with forearm pronated and the wrist in the neutral position. MP and IP joints relax in partial flexion. Stabilize at the wrist and metacarpal slightly above the supporting surface. Palpate the EDC tendon where they course over the dorsum of the hand. In some individuals, the EDM tendon can be palpated or visualized just lateral to the EDC tendon to the fifth finger. The extensor indicis tendon can be palpated or visualized just medial to the EDC tendon to the first finger. Observe the patient extending the MP joint but maintaining the IP joint in some flexion. Resist. Provide resistance to each finger individually on the dorsum of the proximal phalanx towards MP flexion. MC extension. Gravity eliminated. The patient is seated with forearm in mid position and the wrist is the neutral position. MP and IP joints relaxed in partial flexion, hand and forearm resting on the ulnar border. Stabilize and palpate the same as against gravity.
PIP flexion for the second through the fifth fingers. Position the client in a seated position with forearm supinated, wrist at neutral, fingers extended, and hand and forearm resting on the dorsal surface. Stabilize at the MP joint and the proximal phalanx of the finger being tested. For the purpose of this video, we will be testing the fifth phalange. It is difficult for the client to isolate PIP flexion, so hold all of the fingers not being tested into MP hyperextension and PIP extension. This maneuver inactivates the flexor digitorum profundus so that the client cannot flex the DIP. Most individuals cannot perform isolated action of the PIP joint of the fifth finger, even with this assistance. Palpate the FDS, flexor digitorum superficialis, tendon on the volar surface of the proximal phalanx. The stabilizing finger may be used to palpate in this instance. Observe the client flexing the PIP joint while maintaining DIP extension. Provide resistance with one finger at the volar aspect of the middle phalanx toward extension. If the therapist is using the index finger to apply resistance, the middle finger may be used to move the DIP joint back and forth to verify that the FDP is not substituting. This is for against gravity. For gravity eliminated, the client is seated with forearm in mid position, wrist at neutral, resting on the ulnar border. Stabilize at the MP joint and the proximal phalanx of the finger being tested. Observe the client flexing the PIP joint while maintaining DIP extension. If stabilization during this motion is difficult in this position, the forearm may be returned to full supination because the effect of gravity on the fingers is not significant. Finger abduction. For against gravity and gravity eliminated, the client is seated with forearm pronated, wrist at neutral, fingers extended and adducted. Stabilize at the wrist and metacarpals slightly above the supporting surface. Palpate the first dorsal interosseous muscle on the radial side of the second metacarpal or of the abductor digiti minimi on the ulnar border of the fifth metacarpal. Remaining interossi are not palpable. Observe the client spreading the fingers with abduction of the small finger, the middle finger toward the ring finger, and the index finger toward the thumb. Resist the first dorsal interosseous by applying pressure on the radial side of the proximal phalanx of the second finger in an ulnar direction. The second dorsal interosseous on the radial side of the proximal phalanx of the middle finger in an ulnar direction. The third dorsal interosseous on the ulnar side of the proximal phalanx of the middle finger in a radial direction, and the fourth dorsal interosseous on the ulnar side of the proximal phalanx of the ring finger in a radial direction. The abductor digiti minimi on the ulnar side of the proximal phalanx of the small finger in a radial direction. Finger adduction. For against gravity and gravity eliminated, the client is seated with forearm pronated, wrist at neutral, fingers extended and abducted. Stabilize at the wrist and metacarpals slightly above the supporting surface. There are no muscles to be palpated. Observe the client adducting the index finger, ring finger, and small finger toward the middle finger. Provide resistance at the index finger at the proximal phalanx by pulling it in a radial direction, with the ring finger at the proximal phalanx in an ulnar direction, and the small finger likewise in an ulnar direction.